Welcome to Healthcare Logic for Growth, the weekly show where we talk life sciences and healthcare in general, things like clinical operations, research, commercial strategy, market analytics, and what it takes for anyone in healthcare to grow in a sustainable way. I'm Eric Marr, your host, the founder of Life Science Logic and a current Life Science Association board member. So whether you're building a biotech, running a rural hospital, leading a home health agency, or shaping healthcare policy, this show is for you. Today's episode is part of a series that we have running now with 10 episodes, and the category is early stage life science and healthcare operations, although today's conversation is related to Medicaid and the requirements and the changes that are happening as we speak. You know, it really applies to much more than just those companies in that category. The title is The Medicaid Clock is Already Ticking, what every small healthcare company needs to know right now. And usually our episodes take 14 minutes, maybe 15 minutes. This one's going to take a little bit longer, so I hope you don't mind, because it has to deal with things that are not only important, but are happening as we speak. For example, on May 1st of this year, just a few weeks ago, Nebraska became the first state in the country to enforce Medicaid work requirements under the new federal law. Not propose them, not pilot them, enforce them. As of that date, adults enrolled in Nebraska's Medicaid expansion who cannot document 80 hours per month of qualifying activity, things like work, school, job training, or community service, are at risk of losing their coverage. Montana goes live July 1st, Iowa is December 1st, and on January 1st, 2027, just over 6.5, 7 months from now, 43 states and the District of Columbia are federally required to follow. And the federal guidance that HHS is required to publish by June 1st, right around the corner, will set the implementation standards for those remaining states. We're not talking about a policy in committee. We're not talking about a proposed rule sitting in the Federal Register waiting for comment. The clock started. The first state pulled the trigger. The dominoes are lined up. For the hospitals, home health agencies, digital health companies, and life science firms whose revenue models depend on Medicaid-covered patients, or whose buyers do, this is not a story you can monitor from a distance and act on later. Later is now, and the companies that understand what this means for their commercial strategy right now are the ones that will be positioned for what comes next. That's what today's episode is about. So what just happened and why does it matter? What's the law behind the headline? To understand what Nebraska just triggered, we need a quick step back to July 4th of last year when the Trump administration signed the One Big Beautiful Bill Act into law. They call it the OBBBA now because it's so long, and it's a sweeping federal spending and policy bill that includes the largest cuts to Medicaid since the program was created in the 1960s. Nearly $1 trillion in reduced federal Medicaid spending over 10 years, according to the CBO, the Congressional Budget Office. Buried inside those cuts is a provision that is now becoming very real, very fast. For the first time in the history of the Medicaid program, work requirements are a federal mandate, not a state waiver option, not a pilot, not an experiment, a national statutory requirement. Adults aged 19 to 64 who are enrolled through Medicaid expansion must document at least 80 hours per month of qualifying community engagement, like I said, work, school, job training, or volunteering activity. And it's amazing because one of the things that you're going to learn about today is that easy? Can that be done? Or how do we manage this? Because if they can't qualify because of those things, they'll lose their coverage. And so what's the scale that we're talking about? Let's put some numbers on this because the scale matters for how you think about your business and/or patients and everybody involved in the Medicare environment. As of mid-2025, approximately 20 million people were enrolled in Medicaid through expansion. That is the population directly subject to the new work requirements. Health policy analysts at the Congressional Budget Office project that more than 5 million of those people could lose coverage by 2034, not because they don't work, but because of the administrative complexity of proving that they do. That is not an abstraction. That is 5 million people potentially moving out of Medicaid and into uninsured status. And hospitals, home health agencies, community health centers, and providers who serve those patients will feel that shift in the most direct way possible in their payer mix, their uncompensated care burden, and their operating margins. Kodiak Solutions, a healthcare analytics firm, projects up to $25 billion with a B in annual hospital revenue reductions from the OBBBA Medicaid cuts overall. Premier, one of the largest healthcare GPOs in the country, put the number at $68.5 billion in hospital revenue at risk just 2026 and 2027. The Commonwealth Fund analysis suggests safety net hospitals, the ones that serve the highest concentrations of Medicaid patients, could see their operating margins shrink by nearly 30%. For small life science and healthcare companies, the risk always isn't direct. It's often one step removed. Your device gets sold into a safety net hospital system whose margins just decreased by 30%. Your home health software serves agencies whose Medicaid volume is about to shrink. Your specialty drug targets a patient population that is heavily Medicaid enrolled, so not good. And there is a misconception. Here's the myth that is actually doing the most damage right now among small companies we work with and talk to on an ongoing basis. This has become more topical during this actual podcast. The myth is this: this is a 2027 problem. It really isn't. Nebraska just proved that. And here's why thinking of it as a 2027 problem is the most dangerous commercial planning error you can make right now. First, the Arkansas precedent. Arkansas implemented Medicaid work requirements in 2018 under a state waiver, the first state ever to do so. In the 9 months that policy was in effect before a federal court struck it down, more than 18,000 people lost Medicaid coverage. Here is the critical fact. The vast majority of them did not lose coverage because they failed to meet the work requirement. They lost coverage because they failed to correctly complete the paperwork proving they met it. I kind of mentioned that earlier, but I didn't want to lose sight of it throughout this podcast. Administrative complexity, not actual ineligibility, drove the coverage loss. That same dynamic is now arriving on a national scale. The CBPP, which stands for the Center on Budget and Policy Priorities, projects that coverage losses from administrative burden alone could affect millions of people who are in fact eligible. People who do work, who are in school, who qualify for exemptions, but who cannot navigate the verification system in time. Second, the downstream timing. Even if the enforcement deadline for most states is January 1st, 2027, the upstream effects on your business start arriving well before that. States are required to send outreach notices to Medicaid enrollees between June 30th and August 30th of this year. That is the moment when millions of people first learn they may need to prove their eligibility to keep their coverage. Anxiety about coverage, confusion about requirements, and early disenrollment will start moving through your potential patient population and your buyer's patient population starting this summer, not next January. Third, your commercial planning cycle. If your next budget cycle, your next market analysis, or your next investor update assumes a stable Medicaid payer mix through year end, you are building on assumptions that the real world is already invalidating. The time to stress test your revenue model against Medicaid exposure is now, not after the first state level enrollment reports come out in Q4. This is not a 2027 problem. This is a mid 2026 commercial strategy problem. Let's talk about what to do about it, kind of what it looks like. And let's start by creating a realistic scenario that we're seeing kind of play out now. I'm having a lot of conversations about this. A home health agency reaches out to us. They operate across 3 Medicaid expansion states, serve a predominantly low-income adult population, and derive about 55% of their revenue from Medicaid. Their leadership team has been tracking the OBBBA since it passed last year. They know the work requirements are coming, but their commercial planning has basically been on hold, waiting for more clarity on how states will implement. The question they bring to us is, when do we actually have to make decisions? The answer is pretty straightforward. You already have to make them. You have to make them now. Here's why. That agency's 3 states have different implementation timelines. One of them is implementing on January 1st, 2027. One of them has not yet announced. The third is one of the states watching Nebraska closely to calibrate its own rollout. In all 3 cases, the outreach notices to enrollees go out this summer. That means, like I said, patient anxiety, confusion, questionable Medicaid eligibility, all that will start affecting their census as early as Q3 of this year, months before a single work requirement is enforced. The agency has 2 decisions to make right now. The first is a financial stress test. If their Medicaid enrolled patient volume drops 10, 20, or 30% over the next 18 months, what does that do to their operating model? Where is the break even? What does the payer mix shift look like if those patients become uninsured rather than Medicaid enrolled? The second is a strategic positioning question. Is there an opportunity here to differentiate by becoming the agency in their market that proactively helps Medicaid patients navigate the work requirement and maintain their coverage? That'd be nice, wouldn't it? Care navigation, administrative support, patient education. These are not just mission-driven activities. They are retention strategies, they are payer mix management tools, and they're good. They're a good thing to help patients and each other with. That is the kind of commercial thinking this moment requires, and it is available to every small life science and healthcare company in this audience if you start now. As usual, I typically try to provide resource considerations that may be a fit, and there's a few ones here as well. Probably should be on your desk right now. Number 1 is the Kaiser Family Foundation. They've published a detailed state-by-state tracker of Medicaid work requirement implementation decisions, all the things that comprise that. It is updated regularly and is the best single resource for understanding where your states stand. It includes implementation dates, waiver status, and state-specific policy choices around verification and exemptions. That is provided when you're done with this podcast. It is provided in show notes. A lot of this stuff is. The Center on Budget and Policy Priorities published a sharp analysis in April titled, States Need More Time to Prepare for Medicaid Work Requirements. It lays out in clear terms the administrative challenges facing state agencies and the specific populations most at risk of losing coverage due to paperwork burden rather than actual ineligibility. It is a sobering read if your business is Medicaid exposed. And NPR published a ground level account of Nebraska's May 1st launch, including the Hospital Association's concern that when patients lose coverage mid enrollment, hospitals end up absorbing the cost of care they can no longer bill to Medicaid. That piece captures the on ground reality in a way that policy documents don't. Again, also in the show notes. One more item to flag and to think about. CMS is required to publish implementing guidance for the work requirements by June 1st of this year. That's next week, right? Next week. That guidance will define the standards and criteria that states will use for verification, exemptions, and compliance. It is the document that will either tighten or loosen the administrative burden on enrollees and providers. Watch for it. It matters. All right. Let's do an episode summary. 3 things to take away from today before we get into the go forward strategy. All right. Takeaway 1. The Medicaid work requirements are no longer a future policy. They are a current operational reality. As a reminder, Nebraska went live May 1st. Montana goes July, Iowa in December, and 43 states follow in January. The enforcement infrastructure is being built right now. And the downstream effects on your patient population and your buyers will begin arriving well before the 2027 federal deadline. Takeaway 2. Coverage loss is likely to be driven by administrative complexity, not actual ineligibility. The Arkansas precedent from 2018 is clear. When you add paperwork and verification requirements to a vulnerable population with limited administrative bandwidth, people who are eligible lose coverage anyway. That is a patient access problem, a payer mix problem, and a revenue model problem simultaneously. Takeaway 3. The companies that treat this as a commercial strategy question, not just a policy update to monitor, right? Something like that, will be in a fundamentally better position 12 months from now. The question isn't whether Medicaid is changing. It is, or probably given Nebraska's position, it has. The question is, what decisions are you making right now in response to that change? So as always, like I said, we have a go forward strategy, your potential go forward strategy, if this applies to your situation. Here's your go forward strategy. It's 5 specific actions for small life science and healthcare companies navigating the Medicaid work requirement landscape right now. Number 1, know your Medicaid exposure number precisely. I mean, this sounds obvious, but most companies can't answer it on demand. What percentage of your revenue, your patient volume, or your buyer's patient volume is Medicaid dependent? If you don't have a clean answer to that question, get one this week, not next quarter. Break it down by state if you operate in multiple markets, especially because the implementation timelines are different in every state. You cannot manage a risk you haven't measured. Number 2, run a coverage loss stress test on your commercial model. Once you know your Medicaid exposure, build 3 scenarios. A conservative case where Medicaid enrollment in your market drops 10% over the next 18 months, a moderate case at 20%, and a stress case at 30%. Map each scenario to your revenue, your payer mix, and your operating model. Where is the margin impact? Where is the break even? What does an increase in uninsured patients do to your collection rate or your buyer's financial stability? If any of those scenarios produce a number that changes your strategy, you need to know that now. Number 3, assess your buyer's financial exposure, not just your own. If you sell into hospitals, home health agencies, clinics, or any provider that serves a Medicaid-heavy population, their financial stress is your commercial risk. A safety net hospital facing a 30% operating margin contraction is not a buyer that is going to prioritize new technology procurement. They are a buyer that is going to defer, delay, and descope. Understand where your buyers sit on the Medicaid exposure spectrum. The ones with high exposure need a different commercial conversation, one focused on operational efficiency and cost reduction than the ones with lower exposure. Number 4, watch for the June 1st CMS guidance and respond quickly. The implementation of guidance that CMS is required to publish by June 1st will set the specific standards for state work requirement verification systems. For companies that help providers manage patient enrollment, benefits navigation, or care coordination, this guidance will directly shape the operational opportunity in front of you. Read it in the week it drops. If it creates new administrative burdens for states and providers, ask how your product or service reduces those burdens. If it creates new reporting requirements for patients, ask how your company helps them comply. Policy guidance, read through a commercial strategy lens, is often a product roadmap. Number 5, consider whether a patient navigation is a strategic opportunity for your business. Medicaid enrollees who do not understand the new work requirements cannot navigate the verification process or simply miss a reporting deadline are the ones who will lose coverage, even if they are eligible. For home health agencies, clinics, digital health companies, and others with direct patient relationships, proactive outreach and education around work requirement compliance is not just a good deed, it is a patient retention strategy. Patients who keep their coverage stay in your care. Patients who lose that coverage will not. The companies that build simple, accessible work requirement navigation support into their patient engagement model this summer will be ahead of everybody and will be protecting more of their Medicaid census than the ones that wait for coverage loss to happen and then try to respond. So that is your go forward strategy for this week. If you have some questions for your hospital, your home health agency, or your company, and you need a little help, we might be able to do that. Go to Life Science Logic and you can see some of the things that we do. Thanks for spending time with me today on Healthcare Logic for Growth. If this episode brought you value, share it with someone in your network who's navigating their own commercial journey. I think they'll appreciate it. And if you have a healthcare-related topic you want me to tackle, leave me a note at eric@lifesciencelogic.com. Thanks again. I hope you'll join me on the next episode.